You are now listening to MedEd Talks Rheumatology, a Vindico Medical Education production. The following podcast series is titled Year in Review, Uncontrolled Gout, Comprehensive Updates on the Latest Management Strategies, a rheumatology podcast series, and is supported by an educational grant from Horizon. To earn CME credit, log into mededtalks.com and search Uncontrolled Gout, Comprehensive Updates on the Latest Management Strategies. Or click the link in the notes section of this podcast to go directly to the activity, take the test, and complete the evaluation. Before beginning this activity, please be sure to review the faculty and commercial support disclosure statements, as well as the learning objectives. Now, here's your host, Dr. Pooja Khanna.
Hello, I'm your host, Dr. Pooja Khanna. I'm professor of medicine at the University of Michigan in Ann Arbor. I'm joined by my colleagues, Dr. Grewal and Dr. Pillinger. Dr. Grewal is a practicing rheumatologist in the community at the East Bay Rheumatology Medical Group in San Leandro, California. And Dr. Pillinger is professor of medicine, biochemistry, and molecular pharmacology at the NYU Grossman School of Medicine in New York, and an expert in gout. Today, we are going to discuss some of the recent presentations from the ACR Convergence 2023, the EULAR Congress, and the American Society of Nephrology Kidney Week. In this episode, we will focus on recent data for current and emerging gout therapies. We know that uricosurics are the most effective drug to inhibit reabsorption of uric acid in the proximal tubules of the kidney. At both the ACR and ASN, we saw data presented on two such targeted therapies to address the systemic burden of urate in the controlled, or what we define as suboptimally treated gout patients. The first was a late breaker on a potent uricosuric agent called AR882 from the phase 2b study. Rob Keenan and his colleagues showed that when patients were treated over a 6-month period and randomized to this URAT1 inhibitor at doses of 75 milligrams or as monotherapy or 50 milligrams in conjunction with allopurinol, the serum urate dropped significantly within the first 12 weeks. Majority of the patients were able to achieve the target of serum urate less than 5 milligrams per deciliter or even 4 milligrams per deciliter, which is the desired outcome in a treat-to-target approach. The drug was safe and was well tolerated and did not require adjustments in the CKD patients or with other comorbidities. So I thought that this was definitely an interesting take on aggressive management of gout. This was also an interesting take on combination therapy with allopurinol. So Dr. Pillinger and Dr. Grewal, I'm curious regarding your thoughts as to whether you would use this drug potentially in your practice in the various populations that you see. So why don't we start with you, Dr. Pillinger, because I understand you have a practice at the VA, which is a special population in itself.
I certainly do. And I was really pleased to see this paper by Dr. Keenan because he trained with us here at NYU. We've been looking for a while now for an oral agent that can be, if perhaps not as effective as pegloticase, at least very effective for some people and more effective than the oral agents that we have for most people. I think we have a hard time in not all, but many people dissolving tophi with the current oral agents because we simply don't get the urate low enough is I think what people think. So these studies are really interesting. I'm looking at the once again, the dual energy CTs from the study, which I happen to have open. The audience can't see them, but what I'm looking at is a before and after, so to speak. And the before is a patient with very large deposits of urate all over their first MTPs on both sides. And afterwards, very little urate deposited. This is a phase 2b study, so it's not the be all and end all, but it's a B, not an A study. It's fairly along, and I think I think we just have to wait for the studies to come out.
Yeah, I agree. I mean, I think it's exciting. In our previous episode, we talked about the lack of treatment options that we have. And for those of us who treat a lot of gout, including you both, it's heartbreaking when the patient fails the few agents that we have. And so, of course, we welcome studies like this. And the fact that this could be very effective as an oral agent is, just icing on the cake.
Indeed. I mean, I think my struggle in my practice is that with allopurinol or with probenecid, the two drugs that we have historically used, it's the dosing. Because once you move past a certain dose, you have to dose it twice a day. And probenecid in itself is twice a day. And the patients usually forget to take their evening dose, for instance. So it's very challenging to get them to that treat to target goal. And if we can find monotherapy, which is once a day, and we can achieve that target, it makes it so much more lucrative to use this option. So I'm really looking forward to this data. So moving on next to our second abstract, where we also saw primary outcomes presented from the DISSOLVE phase 3 studies, a combination of SVP rapamycin, also known as ImmTOR, which is combined with pegadricase, a potent uricase. This two-component drug was designed to provide antigen-specific immune tolerance to the uricase-induced anti-drug antibody production. This was achieved by induction of regulatory T cells that show the immune response, the shift of the immune response towards tolerance instead of stimulation. This concept is essentially similar to what we saw in 2021 in the RECIPE trial, where we knew that pegloticase has the potential of inducing anti-drug antibodies, and we were looking for methods to mitigate that anti-drug antibody production. And Michael, you were one of the pioneers who led the azathioprine study and reported it in a case report. So I think that's where we got our incentive to look at, the commonly used DMARDs that we use in rheumatology, and use that in an experiment similar to the infliximab story in RA, or the adalimumab story in, psoriatic arthritis, for instance, where we gave patients methotrexate, and see if we could apply the same principle. And the same principle was applied over here, where the premise was utilizing a very targeted ADA mitigation strategy, combine it with the uricase, and administer it to the patients on in a once a month dosing. What the author showed was that once a month treatment over a period of 6 months demonstrated statistically significant response rates and reduction of serum urate. What do you think about the potential use of this agent in the future?
Yeah, so I think, to highlight what you said earlier about patient convenience, and, although oral treatments are considered more convenient for the patient, I think adherence is a big problem for our gout patients in particular. And so anything we can do to ease the pill burden and ease the dosing schedules for these patients, whether we're using pegloticase or oral therapy, I think is welcome, because we really want to give these patients the best chance at responding to their treatment, because they have such few options. I think with the recent data, through the MIRROR trial and the great outcomes we have found by adding DMARDs to pegloticase, I think there's still some issues around that. We're still having to dose every 2 weeks, which can be inconvenient for a patient. And then we're adding DMARDs, which adds quite a large pill burden for the patient. So we are having to counsel them on those potential side effects. We're having to monitor a little more. And again, for the patient, it's more pills. And so I think, options like this are welcome, and they're going to enhance patient adherence and patient satisfaction with their treatment. because hopefully we can make it easier for the patient to really complete their therapy, adhere to the therapy, and give them the best chance at good outcomes.
Michael, how about you?
Yeah, well, I think that's completely true. I think, Sunit's points are really well taken. And, we should underline something that both of you said, which is that when it comes to oral therapies, one of the problems is that compliance is abysmal. And, when we sometimes use the expression treatment failure gout, we have to recognize there are different reasons why people have treatment failure. One is it's actually the minority, but a meaningful minority is you push the available therapies as far as you can and they don't work. But another is just they're either not well prescribed, but also they're not well complied with. The studies suggest something like a 37% compliance rate. Sunit, your comment about making it possible for people to comply with therapy is a very important thing.
So I think we also saw there's renewed interest in the gout space in terms of therapeutics with the oral therapies and also with IV therapies. So let's take a look at some of the findings, and I will call on you on your thoughts. We saw several presentations looking at the use of IV pegloticase in patients with uncontrolled gout, and most of this data came from the MIRROR and the PROTECT studies, where the patients were dosed with concomitant immunosuppression to mitigate antidrug antibody development. So let's take a look at some of the findings, and I will call on you, Michael and Sunit, about your practice patterns. One such abstract was presented by Oren Traum in California that featured a pooled post-hoc analysis of all of the pegloticase trial data to examine the cardiovascular events and the thromboembolic events after initiation of pegloticase. When pegloticase was administered biweekly, meaning every 2 weeks, the rates of cardiovascular events and thromboembolic events were similar in incidence compared to the general population. However, it had a lower incidence as well compared to when patients were on xanthine oxidase inhibitors. So that essentially tells us that what? Pegloticase is actually better than xanthine oxidase inhibition. It's pretty obvious that yes, pegloticase works. And in my mind, that's says that I would want to use pegloticase in a patient who has a larger burden of urate as induction therapy to lower, to treat the patient aggressively, lower the urate burden, and then potentially switch out to oral therapies. So I'm curious to know, Michael and Sunit, do you think that these findings mirror your own clinical experience and observations in your patient populations?
I love the notion, Pooja, that that for some patients at least using really aggressive urate lowering up front may represent a very good strategy that would let us more quickly get to a lower intensity therapy and keep the patient well. I have to say, one of the things I take out of this, and I don't know Dr. Grewal, if you agree, but when pegloticase came out, you may remember that there was actually concern about vascular effects. And the reason was that when you degrade urate, there's a fairly big oxidant load. And the conclusion was that it probably was handled, this is above my pay grade, but it probably was handled by the lipid membranes fairly readily, and it was probably okay. I'm really happy to be reassured that cardiovascular and thromboembolic events were not more. This was an old safety concern people don't talk about a lot, but is something to be aware of. And just as a reminder for listeners, if you're going to use pegloticase, the one real issue about this oxidant load is that you can't give it to people who are G6PD deficient. So please check a G6PD before you administer it. But otherwise, this suggests things are perfectly okay, and we can use the drug when we need it. Sunit, do you agree?
Yeah, no, I mean, in a previous episode, we discussed, the relationship between hyperuricemia and gout and venous thromboembolism. And, although we don't quite understand the physiology of serum uric acid completely thus far, we know that there is a relationship. And I think really just in clinical practice, those patients, like you said, who have a high burden, we know that high burden of gout is a high burden of inflammation and potentially higher risk for cardiovascular complications. And now with this recent data highlighting the risk for thromboembolism as well. So I think just really our approach is probably similar between all of us here on this panel. We're treating these patients as aggressively as we can and trying to lower that serum uric acid as low as we can because we know all of the benefits that come along with that. And so really, unfortunately, there's very few options that can do that. But fortunately, pegloticase is one. And so, yeah, it just kind of drives that point home.
Excellent. So moving on, there were also several studies looking at patterns and impact of methotrexate co-therapy with pegloticase. And one of the reasons we encouraged these studies was simply because we wanted to see real-world data. And Watson and his colleagues showed from the mirror trials that there seems to be widespread recognition that immunomodulation can help when administering pegloticase. And in 2022, over 70% of the patients who received pegloticase were actually offered immunomodulation, and majority of these patients received methotrexate. With methotrexate, I think one of the things historically we have worried about is what? Bone marrow suppression, renal impairment, and in our gout population, the alcohol use. So we've been a little afraid of using methotrexate, and that was partly the reason why in the recipe trial, MMF was used, mycophenolate, because it was targeted towards, the T cell proliferation. So I'm curious to hear from you, Michael, that in your VA population, do you see pegloticase being used in conjunction with one of the DMARDs?
Yeah, not just my VA population, but my NYU community, larger community population. Now, it's true that for the most part, it's our rheumatologist administering the drug, and they're very comfortable with methotrexate. Every once in a while, a nephrologist gives somebody pegloticase, and I yell at them and tell them they need to send the patient to rheumatology, but because we do like the business. But I think we're comfortable with methotrexate. It's straightforward. I think the concerns you mentioned are the ones that we had when you earlier mentioned that we took a look at azathioprine because we were trying to avoid methotrexate. So I think there's probably at least a group of patients who ought to use a different immunomodulator. But for those for whom it's not a contraindication, I've seen a very significant uptake.
And I agree. I think I will applaud my fellow rheumatologists out there because I think we've adopted this recommendation and actually updated labeling quite well. And I think that we're doing a good job when it comes to combining the pegloticase with the immunomodulator.
And people listening to us tonight know or should know that methotrexate is the drug that's FDA approved. So in terms of being able to support a request to give pegloticase with methotrexate, it's going to be more straightforward than an off-label approach.
All right, so just a special mention to another study done by Moselle and his colleagues who looked at the clinical trial data from pegloticase as well, looking at what is the patient profile where when pegloticase was used in conjunction with methotrexate or not, would respond to therapy. And what was shown was that with monotherapy, meaning just pegloticase alone, the younger patients and the patients who had a higher body mass, these were the two predictors of treatment failure. Whereas if you gave the patient methotrexate alongside pegloticase, it didn't matter. Age, and body weight were not associated with treatment response. So I think it speaks to maybe the immune senescence that happens as we grow older and we are able to process a variety of environmental triggers as we grow older. But I think there is a lot still that we need to understand and elucidate. So, Sunith and Michael, what do you think about this particular abstract? Because I thought it was quite interesting.
Yeah, I mean, I agree. I think this is really interesting. And I think, knowing the profile of the patient who's likely to respond or who's not likely to respond or who needs closer monitoring or, additional support when they are on therapy with pegloticase, that is obviously data that we welcome. And I agree with you. I think my N is small and this is just anecdotal, but I do see that in my elderly patients, when we can't or have had to stop use of the immunomodulator, thankfully they've done quite well. So I guess that's kind of the opposite of the patient profile here. But yes, I have had those findings in my clinical practice.
I agree, and they're consistent with work reported by Peter Lipsky out of the early pegloticase data. I think the thing I don't know the answer to is, can we actually clearly in younger patients who, shall we say, still have really vigorous immune systems, not using methotrexate or another immunomodulator is not only really unfair to them, but probably setting up for a problem. But I guess the question is it possible to define a group of people based on age or other characteristics who maybe can just get pegloticase? I don't think we know the answer to that fully yet.
Correct. And I think one of the other things that we struggle in our patients with pegloticase is the amount of steroids also that they receive as part of the pre-medications. And we expect them to have gout flares because we are rapidly lowering their urate. And it's kind of a fine balance that you have to achieve between the methotrexate use or MMF use in conjunction with the steroids. How much do you immunosuppress the patient for how long? And if you stop it, will you actually achieve that response again? And, defining that patient profile, I think we still need about a few more years worth of work. And I'm hoping that we can find that data soon. Now, there are a couple more abstracts which were quite interesting. One study looking at the blood pressure changes in response to urate lowering therapy with pegloticase. It essentially corroborated the fact that when patients receive the drug, irrespective of the fact they have CKD or not, they actually respond. But the patients who were on methotrexate and had CKD, their CKD didn't get worse. So yes, it is safe to use in the CKD patients. There is data from the transplant population as well in case reports, but now we have more emerging data. So I think these data do support a role of immunosuppression in urate lowering and mitigating that ADA response and also addressing the underlying smoldering inflammation. So Dr. Pillinger and Dr. Grewal, it was a pleasure. And thank you to our listeners for joining in on this podcast. We hope to see you again. Stay tuned.
Thank you for listening to MedEd Talks Rheumatology. Just a friendly reminder, CME credit can be claimed through mededtalks.com. For other episodes in this series, search for Uncontrolled Gout, comprehensive updates on the latest management strategies.